All right, all set.
So, hello everyone, my name is Nicola Booth and I'm one of the lecturers with this Centre for Behaviour Analysis at Queen's University Belfast, and I am absolutely delighted to welcome Dr. Evelyn Gould to our webinar series and for her fantastic presentation that she's going to be delivering tonight. So Dr. Gould hails originally from Northern Ireland, which we're proud to own and call it out, and is a clinical behaviour analyst and licensed psychologist at the New England Centre for OCD and Anxiety. She is also a clinical associate at McLean Hospital and a research associate in psychiatry at Harvard Medical School. Finally, she is an assistant clinical professor at Keck School of Medicine at USC. So Dr. Gould has 2 decades of experience working with individuals with autism, OCD, anxiety, and other learning and behaviour challenges. She has particular expertise in supporting caregivers and the assessment and treatment of individuals with complex comorbid presentations. In addition to her clinical work, Evelyn is actively involved in applied research and has published articles and book chapters on parent training, assessment and treatment design, and acceptance and commitment therapy. Dr. Gould is also an associate editor of the Journal of Contextual Behavioural Science and is passionate about dissemination of evidence-based treatments and addressing issues of diversity and equality in behaviour analysis. We are delighted here at the Centre for Behaviour Analysis to have Evelyn speak to us tonight on the topic of understanding and supporting young people with OCD and ASD from a behaviour analytic perspective. So as always, if you have any questions or comments for Evelyn, pop them in the chat box and I'll raise them with her at the end of this talk. So I'm going to stop fangirling now and I'm going to pass over to Evelyn. So Evelyn, it's over to you and thanks so much.
All right, I'm going to share my screen. So just so everyone knows, when I share my screen, I can't see anything. So Nicola's going to be on top of stuff and tell me if I'm suddenly talking to nobody and I'm disconnected or something. I'm sharing my screen, takes a wee minute. So hopefully everybody can see my slides. Someone will let me know if they can't. I'm really pleased to be here today. It's an honor. Obviously, I'm from Belfast originally, and I've lived in the States now for about 10 years. And so it's just so exciting to me to be able to present for Queen's, which I grew up like just down the street from Queen's. So it really is my home. Still Belfast anyway, and I think this is like especially both wonderful and also anxiety provoking for me because my family, I think some of my family members are actually watching, which brings a whole other level of mattering to this and for me to do a good job. I have a lot of material, a lot of slides and some videos, and I'm hoping we get through all of it. It's going to be a time crush, but we will hopefully have some time at the end for questions and for anyone who's willing to stay, as Nicola mentioned. So I wanted to start just with some OCD facts, some general facts about OCD. This is a very serious condition that affects about 1 in 100 adults. So it's pretty common in adults, and 1 in 200 young people. That's actually more common than diabetes, I believe. So it's a pretty prevalent problem. It is a whole spectrum of severity from very mild right up to extremely severe. So I tend to work with the more severe cases where, I used to work in the residential program at McLean where we would see young people who maybe hadn't left their house in years, or even maybe hadn't left their couch and were literally trapped in their home in one place for really long periods of time due to this condition. So it ranks really as one of the top 10 most disabling conditions by the World Health Organization. It's also very serious when we consider that people with untreated OCD are much more likely to commit suicide. And part of what's also concerning to me is that this statistic here, that it takes patients with OCD around 7 to 12 years post-diagnosis to access evidence-based care. So that's the focus of my talk today, is going to be what is evidence-based care for OCD, and particular OCD when you have OCD and autism together. And behavioural treatments are, behaviour analytic based treatments, I would say, are the gold standard for OCD. And then lastly, just we're going to delve into this last piece here a wee bit about why do only 1 in 4 clinicians use exposure with response prevention, which is the gold standard treatment. So that's only 25% of people who actually say they treat OCD using these types of treatments, and we'll have a talk a wee bit about why that might be later. And just so you know, there is an obsessive compulsive spectrum. So there are a bunch of different disorders, such as the ones on the screen you're looking at right now, that come under that umbrella. We're only going to be talking about specifically obsessive compulsive disorder, but all of these share very similar features in terms of behavioral function and the way that they work, and they're very, very commonly co-occurring. So if you are treating an individual with OCD, you are very likely to also notice that they are struggling with, for example, trichotillomania, which is a body-focused repetitive behavior, or hair pulling, or skin picking, for example, or even tic disorders. Tic disorders are really common in children who later go on to develop OCD as well. So that's something to look out for. And OCD is generally considered a neurobiological disorder, but there isn't a huge amount, there isn't a total agreement in the etiology of OCD. So in general, me and my colleagues consider this OCD to be really a combination of both neurobiological factors, behavioral factors, genetic factors, environmental and cognitive factors. And around 25% of individuals with OCD do have a family member who's also a sufferer, and anxiety disorders in family members are also really, really common. If you have an anxious child, you almost certainly will have an anxious parent, and that's something to look out for. Most adults, or around 50%, that's not most, it's like half, 50% of adults with OCD develop the disorder in childhood, prior to 15 years, age 15 years, and the mean onset is around 10 years of age. But having worked with these families for a long time now, I can safely say that it very rarely just suddenly appears. It's not something that's just suddenly appearing at age 10. Typically parents, once you start getting into the functional assessment piece and taking a history, parents will be able to share that they notice symptoms of anxiety, maybe tics, other indicators, or related behaviors way before that. And OCD has been diagnosed in children as young as maybe 3 years old. It involves a cycle of obsessions and compulsions, so we've got more on that later, what specifically are obsessions and compulsions. And really my goal through this talk is to emphasize that symptoms can look really different for every individual. So the topography of OCD is very wide and varied and really can look any way, can take any form. And it is the function that really, really matters. And we know from the literature that many people who access care for OCD still continue to struggle, and that treatment is often not successful. It is around 60% of people benefit from behavioral treatment. That means there's a big percentage of people that don't benefit. And I suspect, my suspicion is, and my colleague, Dr. Coyne, Lisa Coyne, who I work with, is that people are not taking a functional approach. They are taking a topographical approach and matching treatment to topography, and not really understanding the why behind what people are doing. And we'll talk a bit more about that later as well. As I mentioned, comorbidity is really common. Common conditions are depression, anxiety, different anxiety disorders, eating disorders, body dysmorphic disorder, and perfectionism. These are the most common ones. Depression is actually the most common comorbid condition. And particularly, I mean, it makes sense when we think about how debilitating this disease is. It really makes sense that people would be depressed, because their lives basically get smaller and smaller and smaller, and they're not able to do anything, not able to do things that really matter to them. In adolescence, so we're talking about youth mostly today, and in adolescence, it's pretty scary. So adolescents are 6 times more likely to struggle with depression than younger kids and adults, although children bring a whole other set of challenges, in that they generally present differently, right? Their symptoms generally look different. So depression in a child, they might present more irritable rather than with low mood. So that gets a little complicated, but we need to think about that when we're dealing with young people, just in terms of suicidality risk. So as I mentioned in the beginning, OCD brings a very high risk of suicide, and when we think about adolescents being 6 times more likely to struggle with depression, we really need to be paying attention to that. And that means treatment planning can be tricky. So it can be difficult to decide what is the primary thing here, what do we need to target first? And often we need to target things concurrently. We need to address depression or behaviors associated with depression through other behavioral interventions like behavioral activation, for example, at the same time as working on the OCD. Or we may need to, for example, with some of the young people I work who really don't have any coping skills and are engaging in really impulsive behavior or high risk emotionality, that we may need to teach them some distress tolerance skills first, for example, before we're going to be able to get into the nitty gritty of exposure-based treatment, and so on. And then, like I mentioned, topography changes over time. So OCD can look one way when the person's really young, and it's a bit of a shapeshifter. That's how my kids talk about it that I work with. It's a shapeshifter. So over time, it starts to look different. The function is the same, though. So that's where the functional assessment piece is really important as well. OCD is a family issue. If you start to do this work, especially when you're working with children and young people, you will notice that it is a family issue and that you're not going to get very far without involving parents and caregivers. And we have research to show that the severity of the symptoms and treatment outcomes are very much related to the level of family accommodation. So accommodation is just referring to anything that the parents or the caregivers are doing to participate in the OCD or to alleviate the distress. So essentially, children and young people frequently pull others into their rituals. They pull others into helping them, and that creates more problems. It maintains the cycle. And I really feel encouraged by some more recent research here at the bottom, suggesting that actually if you have children and young people, for example, who are not willing to do the treatment, who are refusing treatment, who are not motivated for treatment, you can actually, or you can't get access to them for some other reason, you can actually get very, very good outcomes by just working with parents alone. And as behaviour analysts, we have a whole literature on behavioural parent training. We are all very well aware that parents, supporting parents and helping them learn ways to be more effective in their responses to their children's distress can really, really help. We kind of already know that, or we should. So what are obsessions and compulsions? So we're going to get into the details of this now. In order to get a diagnosis of OCD, you have to have obsessions or compulsions or both, and they have to take up a significant amount of time and cause some distress and impairment. So let's look at that more closely here. So obsessions are simply persistent, recurring, intrusive. So they're experienced as intrusive thoughts. They can be thoughts, they can be urges, they can be sensations or images. So the really, really aversive private events we're talking about here. And they're perceived by the person as inappropriate, distressing, or uncomfortable. So I think it's really important just to clarify that we aren't just talking about, obsessions aren't just thoughts. Right? Sometimes they can be just feelings. So I have plenty of young people where they really struggle with just this feeling that things aren't right. Things don't feel right. It's a just right feeling or not right feeling. Sometimes it's a feeling of disgust. Sometimes it's anxiety. Sometimes they don't have thoughts as much as there are distressing images that they're struggling with. So it can really take any form. And then compulsions are repetitive behaviors. So that means they can be overt or covert. So that's important to notice as well. So sometimes people think of OCD as being a compulsion being something like hand washing, which is very much observable to others around them. But compulsions can also be things you're doing in your head, right? They can be covert behaviors. So things like self-reassurance, figuring it out, anything that you're doing in your mind or ways of thinking that are designed to reduce distress or prevent a feared outcome, also considered a compulsion. So obsessions are essentially like a distressing, aversive stimulus, and then the compulsions are what you do in the presence of that stimulus in order to escape or avoid. And the other piece is so you might have already be thinking this, we all struggle with obsessions, right? We all have unwanted thoughts and feelings that we don't like. That is part of being a human. There has been some literature or research around occurrence of intrusive thoughts in the general population, and I think it's something like 95% of people struggle with some kind of intrusive thoughts, and I think the other 5% are lying, or there's something very wrong there, because we all get feelings, we all experience discomfort. And then the compulsions are really anything you're doing to feel better, and so we all have compulsions that we do, and it's not always a problem. So I might engage in, I feel stressed, so I have a glass of wine in the evening. Not a problem, but if I notice that I'm starting to feel distressed and then drinking a bottle of wine every single night of the week, that could be a problem. So we all do these things. Facebook is another one, or social media. We all scroll on social media as a way of like avoiding stuff, right? Things that we don't want to think about. Not necessarily a problem, but in OCD, the obsessions and the compulsions have to cause marked distress, and they have to be time consuming. It's a wee bit arbitrary. So you can see here the criteria are more than an hour a day, which is, I guess they had to put some kind of measure on there. But they do put here, they can cause significant interference in functioning. So if they weren't taking an hour a day, but they were causing a significant interference in functioning, it could meet criteria for OCD. I think this is also important when we get into a wee bit later talking about autism. So we do see similarities in autism in terms of repetitive behaviors, which can look like OCD or obsessions, things that can look like obsessions, but the function matters. So in OCD, the compulsions are always about negative reinforcement. They're always about getting away from something. There's always distress, and the person does not want to have the obsessions. They do not want to have the compulsions. Sometimes we can see repetitive behaviors in autism, for example, that are not maintained by negative reinforcement. I mean, perhaps there's positive reinforcement there, self-stimulatory behaviors, for example. So you really, really do need to be looking at function and how this all works when you're thinking about OCD versus autism. So I'm going to share a little video here. I have to stop sharing my screen because I want these kids to you're going to hear some kids talking about their OCD and how it affected them. And I think it's a nice illustration of what I'm talking about here. So you can see some examples of what OCD actually looks like. Let's see if this works.
When I would go to bed, I would have to fix my curtains not just once or twice, but like 10 times, a lot of times, more than that. So it would take me about an hour to go to bed.
Most of the rituals that I had, they all had like different meanings behind them, but one of the things that I had to do is like I could only wear certain clothes, and if I wore another shirt or another pants, I would it would just say something bad would happen to like my family or friends.
I had a lot of contamination fears. I didn't like to touch door handles, shake hands with other people, just in fear that I would get sick or catch a disease, or that there would just be germs all over me, and I could transfer it to my family and friends.
Sometimes if I saw something that I'd never seen before, I would still like find out what's not right about it, and then I'd basically find a way to like annoy myself. I'd find a way to hurt myself and be like, oh, that's not perfect, don't look there, it's gonna mess you up, and it'll like, or I know it'll like, something bad will happen to it, or something bad will happen to me if I keep looking at it or something. And I was like, it came to the point where I was like, if I was like, I kept looking at something bad, I was like hitting myself and trying to like like just not look at it, like run away or something. It wasn't very good.
I knew all this stuff was fake, but it was hard for me to say no and stuff. So I knew that it wasn't gonna happen, but like, I know that it's unbelievable that I'm just gonna poof and I'm a bodybuilder, but it's just so real to me in a way.
So you can see in that video that OCD can take many, many forms. So some of these kids were struggling with contamination fears. The obsessions were around getting sick and being contaminated in some way. And then some, I think Ariel was talking about harm-based obsessions. So fear that harm would come to her, or fear that she might get her family sick, harm would come to others. Very, very common. And then there's a few little nuanced examples in there, idiosyncratic examples. There's the little boy at the end who actually had fears around that he was worried that he was going to suddenly become a bodybuilder. If he didn't do certain things, he would just, as he described, poof, be like a bodybuilder. And he was very, very afraid of bodybuilders. And was doing a whole bunch of rituals around to try and control that and prevent that from happening. I'm going to try and share my screen. Hang on, share slides. Here you go. And you can see how these young people get stuck, right? There's the trigger and the obsession. They're feeling these aversive private events, the arousal and distress, and then they do something, which is really normal. Of course, we want to feel better. We don't want to feel these things. And so they do a bunch of rituals or a bunch of avoidance or escape, stuff designed to escape from the distress. And that provides immediate relief, right? There's that negative reinforcement spiral. And actually that makes the person more likely in the future, of course, to then avoid getting triggered in the first place. So you've got this escape and avoidance cycle that just maintains the condition and actually gets worse and worse over time. So your world just kind of gets smaller and smaller and smaller and smaller the more you avoid, and the more the ritual is reinforced by escape. And as behavioral analysts, we can see that there's some key behavioral processes here that I'm not going to get into the details of, because you should already know these as behavioral analysts. But there's the classical conditioning piece, right, where these stimuli acquire versus functions through direct caring. Then you have the operant conditioning piece, where we have discriminative stimuli being established for escape and avoidance. And there's also this languaging piece which allows this massively rapid expansion of networks of stimuli to avoid and escape through derived relational responding. So how these young people talk about their experience really matters. And they can go from avoiding just one thing to then relating that one thing to many other things, and now they're avoiding a whole host of things. So a good example of that is a young person I worked with, or we worked with on the unit, who had had attended a summer camp in New York, and the OCD had been triggered by an experience there, and she then had a bunch of contamination fears, and went from just avoiding the camp and avoiding things she took to the camp to avoiding number plates that had New York on it, to avoiding any person that she found out was from New York became contaminated. Couldn't read any articles or books that had anything to do with New York. Then started avoiding all of anything that was remotely related to camp, or any of the things that she took to camp. So it went from the literal socks that she had at camp to any socks at all, backpacks, any kinds of foods that were reminded her of camp. And of course, that just started avoiding more and more things, to the point where she actually couldn't leave her house, and she could only sit on the couch and walk to the bathroom, and that was it. That was her entire life. And she could only interact with her mom. She couldn't actually interact with any of her other family members or any other school friends or anything like that. So her world got extremely small very, very quickly through this process. So I'm going to move on to just chatting a bit about OCD and autism then. So how does this fit? OCD is very prevalent among autistic patients. So you will notice that OCD in the autistic community occurs at a much higher rate than it does in a neurotypical community. And also that autism occurs 13 times, it's a 13 times higher risk. You have a 13 times higher risk of having autism if you also have OCD. So they're very, very much frequently overlapping and also co-occurring. And the overlap between the symptoms, like I mentioned, really complicates the assessment and treatment, particularly if we're not taking this functional approach. And actually, not more on this later, we're going to talk about it right now. So we're going to look at that right now. So if you are just looking at autism and OCD topographically, as in the form, and the behaviors that are happening, you can see the problem. So autism and OCD both involve that rigidity, right? High levels of accommodation from family members, avoidance of change, observable distress and anxiety, and restrictive repetitive patterns of behavior, or restricted interests and activities. Those are things that you might see in both of these. Both populations frequently have difficulties with flexibility and engage in these repetitive behaviors. So what are we going to do? Like, how are we going to piece that apart? I don't know what I'm trying to say. What do we do here? And of course, the answer for us is functional assessment. I do want to, before I get into functional assessment and treatment, I do want to also mention other things that are an issue for autism, for the population. When they go to an OCD provider, OCD providers are generally not thinking about these things as well. And so we know when you're dealing with the autism population, assessment has to be comprehensive, right? It has to address all areas of functioning, not just diagnostic status. And we have to be thinking about not only what's going on here, why is this person engaging in these repetitive behaviors, or why is this person distressed, what's happening here? We also need to be thinking about skill deficits, for example, like, does this person have the skills they need? Is this, what I'm seeing, reflective of skill deficits or developmental delays? Is it reflective of sensory differences or motivational challenges? There's often challenging behaviors that need to be addressed in order for the person to access the treatment. And the autism population, I think, is also quite unique because individuals often come with a lot of other people around them, more so than other individuals. So there's a lot of other providers involved typically, right? The family is very, very involved. We need to be thinking about cultural context. We need to be thinking about the family context and other things. There's often a really complex learning history. I mentioned later, but individuals on the spectrum also have a higher risk of having ACEs, so trauma. Adverse childhood experiences occur much higher in the autism population. We've got to be thinking about that in terms of historical context, and higher rates of mental health issues and so on. And then we also see other things, which you're all probably familiar with, but like sleep problems, feeding problems, and so on. So we've got to be comprehensive about how we approach intervention and assessment. And we're going to do a functional assessment because we're behavior analysts, and it's going to involve all of these things. So just like with autism, with OCD and autism, we're going to look at records reviews. We're going to do some questionnaires. I'm not going to have time to get into which ones or how. We're going to do some direct assessment. We're going to observe. It's never, I was talking to a colleague the other day, but it's never enough for me just to interview people. I always want to observe. Of course, I'm observing while I'm interviewing them. I want to observe what behaviors, what are they doing whenever I'm talking to them? How do they respond to certain questions? What are they saying? What's their language use like? How are they interacting with caregivers? But it might also involve me going to their school or observing them at home doing certain activities and so on. And then functional analysis is absolutely critical. And that's you know, really thinking about this at the micro level in session. While I'm talking with somebody, I am always doing functional analysis. I'm intentionally changing factors in the environment and observing what happens, including how I'm using my language. And then I'm also doing it at the more macro level too, as a kind of bigger intake process in order to formulate the overall treatment plan. But I just think it's important to remember that functional assessment is like an ongoing iterative process. It's part of the intervention. We don't just do it one time at the beginning and then we're done. Where every session I'm analyzing function and trying to determine, like, okay, I'm going to say this right now. Let me observe how that impacts the individual, and do I need to change anything? Like, what am I going to do next? Could do a whole training on that. OCD treatment, these are the evidence-based treatments that we use when we're working with individuals with OCD, whether they have autism or not. So exposure with response prevention is the gold standard, and or with medication. So with medication alone, the research says maybe 40%-ish of people will benefit. However, around 50% of people stop taking their medication because of side effects. So that's a huge barrier and huge issue. And only 40% are going to get better anyway. Around 60% of people, like I mentioned, get better with behavioral intervention. So that's a lot. That's a big difference. That's a lot more than just meds alone. When you combine meds and exposure, I think it's around 70-ish% of people benefit. So only 7 out of 10, or you could say, wow, 7 out of 10, but what about this 30%? And like I mentioned, I think I really believe that a lot of the people that don't benefit would if we took a more functional approach, and a more team-based approach to our treatment. ACT is also excellent. We use ACT in our clinic, but always in conjunction with standard ERP. Family-based treatments are really effective. So the SPACE program, supporting parents of anxious childhood emotions, that's been developed at Yale University, is an excellent parent training program specifically for parents of anxious kids and OCD. However, they have really great adaptations for ARFID, and also, which is, you know, picky eating, ARFID, which is common in autism, and also for young adults who are struggling, or failure to launch type cases as well. They've got some good research coming out now on that. Always using ABA, always in combination with ABA, especially with young people and children. And then there are other related treatments here that you would use if there were other things going on too. And always function-based. Exposure-based treatment is what it says it is. So it simply involves exposing. I'm going to show you a video soon in a wee minute to show you what this looks like. But it's essentially just exposing someone to the aversive stimulus, and then just checking the time here, my gosh, and then resisting engaging in that escape or avoidance behavior, right? So this is how it works. We have the unwanted private event. So maybe it's a thought like, I have a young person right now that I'm working with whose obsessions are involve intrusive thoughts about that she's going to stab herself in the eye. And her intrusive thoughts are around, I'm going to hurt myself. I'm scared I'm going to hurt myself. So she experiences, when she has one of these images, this is the unwanted private event. And typically what she's done in the past is escape or avoid that. So she's done things like hide all of the knives in her house, or avoid, and she will now, she's doing amazing actually, but when I first met her, she wouldn't cut anything, which makes it really hard to make food or eat food. She wouldn't use pens or pencils because she could use those maybe as a weapon. She couldn't use nail files or touch anything, hairpins, anything that she thought she might potentially use as a weapon. She also avoided various other potential things that might cause her harm, and she was obsessively checking herself in the mirror as well to check if she had actually harmed herself. So she would check her eyes constantly to make sure she hadn't harmed herself. So when we started doing exposure, we want to do two things. We want to block the avoidance or the escape, right? So I wanted to help her stop avoiding holding pens, stop avoiding using knives, stop avoiding all of those other things, and also block the escape. So when she had the urge to do something to feel better, we wanted to work on her not doing that, her resisting that urge. But it isn't just that. Our goal is actually not just to break the cycle between the anxiety or the unwanted private events and avoidance. We also want to shape approach behaviors, right? We got to make the person's life bigger again. It's not just about habituation anymore. The goal is to broaden the repertoire in the presence of those aversive stimuli. So get that person doing a whole bunch of new things that we can reinforce in the presence of the aversive. So expanding the repertoire and really helping them learn a variety of different things to do whenever these stimuli are present. And this is kind of what it looks like. And apologies if you are scared of spiders. So when you're presented with an aversive stimulus like this in OCD, it is everything. It is all you can think about. It is all you can see. Your repertoire is really narrow and you're not noticing the whole range of your experience. You are absolutely focused on avoidance and escape. And our goal is this, right? So we are not going to get rid of the stimulus. We're not going to get rid of the anxiety. That's actually OCD's goal. So actually reducing anxiety, to me, is kind of reinforcing OCD's message, which is you can't feel anxious. You need to do something about that. So our goal is actually, how do you let that be there and do a bunch of other stuff in its presence? So that values-based living idea that we see in acceptance and commitment therapy. So it's not about getting rid of stuff, it's about new learning. We also know in behavior analysis, we can't unlearn stuff, right? Once you've learned stuff, it's there. So we need to focus on learning new stuff and helping our clients in terms of allowing treatment to be scary and difficult, but also ultimately very, very meaningful. And as I mentioned, that is what acceptance and commitment therapy informed ERP is about. It's about shaping flexible, effective behavior, even in the presence of aversive private events. And just to say, like, I don't really have time to go over this, but we do know in behavior analysis a lot about promoting variability in autism already. And we use, to me, as a behavior analyst working in this realm and using ACT, I am doing all of these things when I am doing ACT. I am helping people notice the full range of their experience, broadening their repertoire, and then reinforcing, differentially reinforcing other stuff other than avoidance and escape. And I'm really doing what helping them do what this little girl is doing here in the presence of this monster, this OCD monster, continuing to color, continuing to engage in an activity that she really loves. And this is what it can look like. So I couldn't show you a video of Autism Client, although I do have one at the very end that I might have time to show you. But I wanted to show you this 1-year-old because she has limited language, and I know that many of you probably work with individuals with pretty limited verbal repertoires. And really just want to emphasize, you can do exposure and you can shape psychological flexibility from birth. Right, it does not matter. I get asked a lot, when somebody ready for ACT? And my answer is, well, it depends how you define ACT. And if you're talking about shaping flexibility, you can do it from birth, but it's always in the presence of others. So you're going to see this father teaching his daughter different behaviors in the presence of the scary stimulus, which in this case is the scary clouds. So I'm going to show you this video now. See what you notice. See what you notice this father doing. Okay.
So do you want to tell me about the clouds outside?
Oops. It's not playing for some reason. Apologies. Let me try again.
Hey, stop.
Yeah.
Can you click play in the bottom left corner? Is it paused?
It looks like it didn't upload properly. Actually, it looks. Hang on. It looks like there's only 8 seconds on the video, so let me try again. I'll try again. Yeah, it looks like it's only 8 seconds. Is that?
Okay.
Hi.
That's weird.
Is there a way? Yeah, it is weird. I don't know.
Yeah, I just pasted it in the chat. So people can, you want to just give people a second to watch it in YouTube?
Yeah, I would stop it after around 5 minutes. We don't need to watch beyond 5, but is there any way for me to share the video at all? No?
Let's see. Click videos tab and click stop sharing.
Okay.
Let me see what happens when I do it.
So do you want to tell me about the clouds?
Yeah, you're right.
Outside?
It's only showing 8 seconds.
Yeah.
Hang on, I can share it from my browser. Give me 1 second here.
Okay, great. Yeah, so just, I saw in the chat, this is not a child who's diagnosed with OCD, but this is this is just an example of what exposure looks like with a really young child who doesn't have a lot of language. And of course, exposure is for not just OCD. Exposure is how we work through lots of fears and anxiety. I practice exposure myself, like every day. Like this, actually doing this presentation is an example of that. Because I'm very anxious when I present, but I'm doing it anyway. So we don't hear anything. That's the only thing. I don't know if others can hear that.
Hold on, sorry. How about now?
Yes.
The clouds?
Yeah, just quiet. Yeah.
What do you think about the clouds? You want to go inside? Okay. Well, should we go sit on the table instead? Come here. Come in here. Come in here. Here, I'll hold you. Okay. All right. Oh boy. All right. Come over here. You sit on the table. Let's watch. Okay. What do you see? See some clouds? Yeah. What do you think of the clouds? Yeah. Here, come here. Sit with me. Can you say, hi, clouds? How are you? Do you see how fast they're going? That's pretty cool. Look how fast. Do you see the sun? Where's the sun? Yeah. Whoa. Do you hear any birds chirping? There's a bird. Yeah. There's a cloud. Say hi, clouds. How are you? Yeah. Is it a little cold out here? Mama. You can stay here with Dad. Okay. So, do you want to wave? You want to wave to the clouds? Like this? Say hi, clouds. Whoa, look at that big bird. Wow.
You can see it on the show.
You say that, hi, clouds, you're moving so fast. You say, yes. I love. Can you say, I love the clouds?
So we could maybe stop it, and I can just, people can watch
Let's
it,
hang
but
out
just to give you a sense. Thank you so much for sharing, Chris. So what you'll see in the rest of the video is, and you know, well, I'm not, let me just pause. So what you'll see in the rest of the video and what you see there is that the dad is trying, he's trying to teach a bunch of new responses in the presence of the scary clouds. So you see him encouraging her to notice that not just the scary clouds, but also clouds, there's birds in the clouds. Look, you can point to the birds. You can point to the sun. Isn't that cool? There's a whole bunch, he's introducing a whole bunch of other functions there. And later on, you'll see how she's it's over a series of sessions, but she starts to play on the slide and do fun things whilst the clouds are there. And actually, you'll see that eventually she's like laughing and smiling and being like, hi, clouds, and then kind of smiling, and really transforming that experience with her. And you probably also noticed how the relationship she has with her dad really matters, right? He creates that safe context for her to try new stuff, to learn, to expand her repertoire, even in the presence of the scary clouds. He models for her. He stays very calm. He doesn't rescue her. He doesn't force her, but he also doesn't rescue her. It's a cool little video. It's not perfect, but it's a nice example, and it's hard to find actual examples on YouTube. All right, let me share my screen again. And actually, he doesn't, I noticed the plan ignoring comment, he actually doesn't ignore her, right? He doesn't ignore, he validates it. He says, oh, you're saying you want to go inside? I know it's scary, but how about we hang out here for a little bit? Let's hang out a wee bit more. Look, what else can you notice? Right, so I really like that, because he doesn't invalidate her or gaslight her. Doesn't be like, don't feel scared. They're not scary. He doesn't tell her they're not scary. He doesn't say don't feel the way you feel. He doesn't ignore her. He notices and labels and names that she's scared, that it's hard, that she wants to go inside, and let's hang out for a little bit longer. And let's see what else might be there for us. And of course, that's very important, because if she can't go outside, her life is going to be very small, right? She needs to be able to leave her house. There's fun, not only are there fun things in her garden, which you'll see, trampolines and slides and fun stuff, but also she's going to need to go to school. She needs to go out with her parents shopping. They want to go to family events, go to church, do all of their stuff. Very important.
Hey, Evelyn, just giving you a heads up.
Yes.
I tested the other two videos and they're fine, so you can play those.
Okay, great. We might not have time for them after
enough.
all that, but we might have time for one.
Okay.
I'm going to see what I can skip through here. But thank you, I appreciate it. So some ACT-based questions, these are the types of things that I'm curious about whenever I'm doing my assessment. So with this little girl, I might be asking, well, what's the spider? Or what are they avoiding? What's the scary thing? And for her, it's the clouds, right? It's whatever, it's the fast moving clouds. What would she be doing if the spider wasn't there? Well, she'd probably be playing on the trampoline, going on the slide, pointing at the birds, hanging out with dad, laughing and playing. What's she doing instead of that? She wants to stay inside. She's staying in her house and she's not doing those things. She's avoiding, she's escaping. And then I'm thinking about, well, how do I welcome the spider in? Right? How do I help this person choose to stay in the presence of the spider? How do I get the spider in the room in a non-coercive way? That's really, really important. How do I get this child to choose? How do I shape curiosity? And what do I want to get her to practice with it there? So once I have her in the presence of the clouds, what do I want her doing instead? What do I want her to practice? So you saw the dad having her label her emotions, label the clouds, label the birds, point, have a conversation with him, jump on the trampoline, do all these different things. I'm going to end with just saying two things. We'll talk a little bit about autism, some things to bear in mind again, and then also this, right? The price of admission to doing this work. And the big problem is that both clients and clinicians, and I would say parents also, struggle with the same problem. So we have a message, especially in westernized, white westernized societies anyway, the message is anxiety is toxic and bad. And it should be fixed to be mentally healthy, right? Emotions are labeled as toxic and bad. Feelings, discomfort, you shouldn't feel uncomfortable. You shouldn't have that emotion. We all struggle with the same problem. And how, if we have that message, how do we show up for somebody else's distress, right? How do we get someone to choose to do really hard things if the message is don't feel that? Or you can't handle your emotions is another common one that's kind of shared. It's like, can't be scared, it'll be too hard, I won't be able to handle it. How do you show up to the other person's distress? And that requires therapists to engage in exposure. And I put this picture up here because I'm really, really afraid of heights. And I have had to also literally engage in height exposures with clients, be willing to do that, but also just be willing to practice acceptance around my own anxiety that's going to show up whenever my client's anxious. And sometimes I have to do really challenging exposures where the content or the topography of the thoughts or the obsession is pretty hard for me. So my client with the harm OCD, for example, who has fears of harming herself, and I am sitting there doing an exposure with her where she is holding a fork up to her eyeball, and we both have to sit in the space of fear, and the possibility, the uncertainty, and the doubt, right? She could stab herself. I could do it. We're all capable of all of these things. It's the uncertainty, sitting with that uncertainty and that doubt that comes with OCD is really hard. All humans hate ambiguity for the most part, and actually mammals as well. We don't like uncertainty. So it takes curiosity and willingness to do this work. Even when there's pain and discomfort, it takes a real solid understanding of behavior analytic principles and trust in the process and functional assessment. And it takes learning how to be psychologically flexible yourself, and in order to help others be psychologically flexible. So clients and parents and so on. So willingness to be with rather than fix discomfort, in order to go after the things that matter to you and also go after the things that scare you, because those are always connected to the things that matter to us. We do that by creating a context for thriving for ourselves, for our clients, for their families, creating a nurturing environment. It's only in a nurturing environment can new behaviors emerge, can people learn new stuff. So using our words and actions to promote that nurturing environment. And sometimes for some of my clients, I might be the only nurturing environment or interaction that they're actually experiencing, especially if they're coming from really adverse contexts. It includes creating this for parents, as I mentioned, and teaching parents how to do this for their children. So you saw that the dad actively trying to create a nurturing context where she would be willing to learn new ways of interacting with that experience that was so difficult for her. And practicing and demonstrating compassion is part of that. That's how we create that secure base, like I said, it supports that exploration and variability. And then I'm going to show, I wonder, we've got like 5 minutes left. I can show you a few minutes of this video just to get a sense of what just the bravery that's involved in this work. Escape, show video. Okay, this one's supposed to work. I'm going to skip to here.
The subway together, Siddhartha returns to the Center for Anxiety
Just skip over here a wee bit.
and how to deal with the fearful thoughts she often gets during a panic attack.
In some ways, it takes a leap of faith. The patient is so very fearful, and you're having them confront their worst fears.
She has a meltdown. What if she has a panic attack right there?
Just going to skip over this for time's sake so you can see what this actually
Finally,
looks like.
a sort of panic attack chaser. Siddhartha is asked to drink an entire bottle of caffeinated water to actually heighten her anxiety so she can more fully experience the exposure therapy.
We're going to start today. Where do you think we're going to start?
In the elevator.
Yeah. How do you feel about that? What's your anxiety from 0 to 10?
Like 10.
For Siddhartha, like some other agoraphobics, elevators feel like vertical tombs. She hasn't used one in years.
Ready?
She'll take the stairs or nothing at all.
You can do it.
But not today.
Okay. It's okay. Just step in.
As it turns out, getting in is the easy part.
What's your worst fear?
That we'll get stuck.
And then what?
And we'll die in here.
Okay.
The therapist is steady and reassuring, but it's still 15 minutes before Siddhartha can even attempt to close the door.
I'm thinking, I don't even know if I can do this.
Why can't you? What's holding you back?
I'm afraid. I'm so scared.
It's your fear. This is hard.
Under therapist Sandra Baker's guidance, Siddhartha experiences a full-fledged panic attack.
And I have all these anxious thoughts about what will I do when the door closes.
For Siddhartha, simply being able to ride this elevator will become an act of terror and ultimately liberation.
I'm going to take my hand off of the button, and I want you to feel the anxiety. It will not hurt you. I'm taking my finger off. You're okay. You're okay. You're okay. That's just a behavior. That's anxiety. Feel it. You are fine. Look at how fine.
What are we doing? Oh my God.
Just let it come
Oh
on.
my God. Okay, I'm gonna let go of you, Sandra.
Finally, Siddhartha breaks through her worst fear.
You're doing it. This is great. You're doing it.
Oh my God.
Okay. Now don't go out of the elevator yet. I want you to just stay.
Eventually, like removing the training wheels, Siddhartha has to do it on her own.
Ready? Okay. You can do this. Oh, this is hard. She's going down.
Repeating the experience again and again breaks the back of her fear. And with each successive trip, Siddhartha's anxiety decreases.
Exactly.
Having taken her first leap of faith and found herself still mentally on solid ground, the next step was slightly easier. Back to the subway, again with therapist in tow. This time, although she was a bit nervous, she was
I'm going to stop the video now. I don't know how to stop the video. Oh, there we go. Okay. So you get the idea just in terms of like, it's a shaping process and how the relationship that you have with the client really, really matters. Like that relationship provides the context for the person to start doing some really hard stuff. And it's always in the service of what they care about most in their life. I'm going to we've got like 1 minute probably left. So I'm going to just recap. Now I'm anxious. I don't know how to share. I forgot how to share my slides there. That's what happens. That's how narrowing the effects of aversives are on our behavior. Like I can't even remember how to do something like share my screen. So again, just to wrap up, autism changes how we go about doing treatment. Right? We have to consider the needs of this population from the beginning. We're going to need individualization around these really powerful behavioral tools that we have. The gold standards of treatment are still going to need that individualization. We're going to have to spend more time on the relationship building skills. Like I just said, that matters so much. So I often have to spend a lot longer and it's slower. I need multiple learning opportunities. I need to spend a lot of time building trust, pairing myself with reinforcement and so on in order to start doing this work. And we got to essentially do all of these things, right? We need to adapt the environment. That's going to be addressing skill deficits as well as accommodating. If we're not addressing, we're going to have to figure out workarounds. Do we need to do compensatory stuff? How do we structure the sessions? Do we need more visuals and so on? We got to teach different skills, more and different skills, not just the ERP skills, but we may need to teach particularly like tacting emotions, tacting physical sensations, also addressing social skills deficits and whatnot. We're going to have to do more work on the motivational end of things, as you all will be familiar with, and then establishing a village to really support this ongoing care. And that includes supporting caregivers. And BCBAs have a lot to offer. So I really, really want to emphasize that we have the ability to create powerful teams in order to, sorry, I skipped over that, in order to support this population. And teams is the way forward. In terms of like just addressing the diversity and the needs there. I don't think that one psychologist in their office is going to fix or address the needs of these individuals anyway. It may work with a very high functioning adult to go to an office and do exposure, but I think probably we can all generally agree that most of the people we're working with are not going to benefit from that. And that is it. I'm sorry we didn't have more time. to go through this. I've got to click through this. And I do have the slides available for you. Oops. I do have the slides available for everybody who would like them. If you want, you can email me, or I actually shared them with Nicola as well, so she can share the rest of the information that we didn't cover as well. And that is it. I'm going to wrap it up. We're 3 minutes over.
Thank you so much, Evelyn. I'm just reading some of the comments are coming in, and everybody wants a longer session with you next time. So
okay, that's nice. That's very kind.
And we do have some questions in, and I'll just read them out for you. Somebody said, if Sean O'Neill said, if there's time at the end, could you talk a little bit about what distress tolerance would look like for a young kid?
Well, you're not going to like any of my answers because they're always, it depends. It depends on what my assessment says, and what their skill set is, what developmentally where they're at, and why am I teaching the distress tolerance skills. So it's really important to think about function. And so with OCD, what I don't want to do is I don't want to teach them more avoidance strategies or more control strategies, right? So I don't want them using distress tolerance as a ritual. But I might need to teach somebody who, for example, is going from 0 to 10 and is harming themselves or harming somebody else, or is likely to, just has zero ability to tolerate difficult feelings or emotions. I am going to need to teach something there. Particularly my clients, it tends to be suicidality and self-harm and things that happen when the person is really, really distressed. And so I would need to teach some skills there, but it could look like anything from, I mean, for sure, one of the first component skills that I'm teaching is labeling of emotions, describing what they're feeling and noticing. So can the person tact what's happening? Can they tact their environment, stimuli in their environment? Can they tact emotions, private events? That would be one of the main basic skills. But it also might be self-soothing, like ways to self-soothe, or how to recruit supportive parenting from parents. So I do an awful, with a really young kid in particular, I'm going to do parent training, actually predominantly work with parents and not the kid. And I'm going to teach parents how to respond in non-punitive, supportive ways when their kid's experiencing distress, which is not rescuing. I don't want them to rescue, but I want them to prompt and reinforce adaptive coping and to model that for their kid. And also not to invalidate, not to be like, suck it up or just stop feeling like that, or be really demanding and tell them to just dry your eyes and pull your socks up and get on with it. So, and I'm sorry, I know you're probably looking for more specific plug and play there, but that's not what we do in behavior analysis, right? It's very individualized and based off whatever my assessment is of the needs and what's going to be workable. And I'm thinking about long term, because OCD particularly is all about what I'm feeling right now in this moment. I need to get away from it, and how that might work in the short term, but in the long run it starts to get in the way and it starts to create bigger problems. Yes, hopefully that helps.
Thank you. Okay, I have one from Bobby saying, are we sure that it is not onset until age 10? I think it is from your initial slides.
No, it wasn't onset. It was just average age of diagnosis. So that's a different thing. That's a statistical in the research. That's what it says. But like I mentioned, I mean, it doesn't magically appear at age 10, typically. Yeah. It doesn't magically appear really ever. I've never really had a kid. I think there are some very unique, there's always exceptions to the rule, right? So there are some very unique situations, for example, with pandas, where that's an illness triggered OCD presentation. But in general, kids, and there's some research suggesting that anxiety sensitivity is a thing. So related to temperament, that certain individuals are biologically prepared or unprepared, whatever way you want to talk about it, are susceptible to developing anxiety issues for whatever reason, and we don't really understand why. And it's also, in retrospect, we don't have ways of predicting who's going to get OCD or not. And that goes for pretty much all of the DSM-5. But the average age of diagnosis is around 10. And that certainly we get younger kids who are presenting with these symptoms, and certainly many people don't present for diagnosis till older, and that is part of the issue also with this number, because we know that people with OCD often are embarrassed about their symptoms. They don't understand. They go to providers who also don't understand, especially when the obsessions are not washing your hands or not contamination, washing your hands. So my young person that I'm working with who has the harm OCD has been told it's all kinds of different things, from you might be a psychopath, or are you suicidal, do you have a personality thing, like all of these other things, without really looking at, because they're not looking at function and how this works for the person, and they're not understanding what's going on. So, you know, and I mentioned also, even if you get a diagnosis, it usually takes you 7 to 12 years to actually come into contact with a behavioral therapist who understands what OCD is, and somebody who actually uses ERP. So even if you get someone who treats OCD, there's a good chance that they won't even do the treatment. So it's a huge problem. The numbers are problematic.
Okay, thank you. Daniel, do you anticipate an increase in OCD cases, incidents, post-pandemic, given the year of fear, do you think?
It's such an interesting question, because I also had people ask me, has it got worse during the pandemic because of contamination fears? But I think, one, we don't have the research yet. Obviously, this is the first time anyone's been through a pandemic. No one knows how to do this, and the research is only being done right now. I personally, of course, this is anecdotal and from my circle, have not noticed in contamination related OCD. The people that are struggling from that I come into contact with already have contamination OCD, and so COVID obviously gets wrapped into that. I definitely, for sure, there's going to be more anxiety and more mental health, depression. I see that already. I'm really concerned about what's going to happen when everyone here goes back to university in person. I think our mental health services are going to be overwhelmed from a student's perspective. I certainly could see how the pandemic, conceptually, I could see how the pandemic, if you have a propensity to be anxious about health or anxious about contamination, how that could escalate that. It's also very problematic, because now it's ridiculous. In our clinic, we're having to do essentially rituals. Like normally, my partner laughs at this all the time, but I am anti-hand sanitizer, eat stuff off the floor, right? I eat things off toilet seats all the time with kids and do all kinds of gross stuff. And so now we're in an OCD clinic and we have to wear masks and we can't touch stuff and we have to sanitize everything. And so yes, I totally see how that could reinforce. If you have OCD, that could make it worse. So, but it's an empirical question, I guess. Like the data, I don't have the data yet.
Not yet. Come back to you in a year, will we? Or a year and a half?
Yeah, whenever I'm like losing my mind and being like, I need.
Yeah. We'll have one more question here from Megan. This was from earlier in your talk, the significant interference in functioning. If you're a teacher in the classroom and you're identifying that these obsessions and compulsions are barriers to academic success, but the student doesn't identify this as an area of significant interference, does the student individual need to view the behaviour as significantly interfering? I'm assuming that's in order to put an intervention in place.
Let me ask this question. Do people get diagnosed who don't agree with the diagnosis? Sure. So if everyone around you, medical professionals, I mean, many kids with autism, for example, they can't weigh in on whether they think they have autism or not, or whether they think they have impairment or not, and the decision has to be made. And it is the same for OCD. So, and there's many reasons. I mean, again, I'm back to the assessment thing, because I want to understand so many questions. I want to understand, well, what's going on there? Is the child embarrassed? Is the child just really developmental? Like, kids automatically have less insight, right? They have less insight into their symptoms because they don't have the language skills or perspective taking that we do. Less insight, they're more likely to believe their thoughts as real. They're less adults, and more language developed individuals tend to be able to see their thoughts as irrational, or that this doesn't make sense. Younger kids, not so much. They tend to be more superstitious and they believe their thoughts more. So there may be different reasons why that person's not accepting. It could also be past history of bad experiences with what does this mean about me? Am I broken? Is this a problem for me? Or they may just genuinely not see the impairment there. And also accommodation, at high levels of accommodation, I mean, there isn't a problem. So I have plenty of kids who come to me and they're like, my life's fine. And I'm like looking at them and going, it kind of is, because everyone's so good around you at not presenting you with anything that's going to trigger you. Everyone's walking on eggshells and they do whatever you say. So of course it's fine. You are kind of fine. So I want to look at that, but I think I went on a tangent there. There is a difficulty in schools in general, at least here, where doing the dance between wanting to accommodate in the sense of academic accommodations, so that the kid is able to access their education, like wanting to figure out ways to help the kid stay in school and access an education, versus reinforcing the OCD and reinforcing avoidance and escape, is a really, really hard line to walk. Mostly, that's where it's useful to obviously on your IEP team have clinicians involved and everybody kind of agree, like, how are we going to, maybe we start by accommodating to get the kid in school and get them staying in the classroom and participating, but then we have to have a plan to try and remove those accommodations, because otherwise this kid's never going to get better and their world's going to stay really small, and it's going to interfere with maybe what mom's trying to do and the team are trying to do outside of the home, or in the home in terms of clinical intervention, because they're getting two different messages. One is like avoid, 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 and the other is like need to face your fears. So it's a case by case complicated situation, I guess. Yeah. Mm-hmm.
Okay. Well, I think, we could sit here all night, and I'm sure there are plenty of people who would sit here, and I would happily listen all night as well. But we really just want to say, Evelyn, thanks so much for your time. I mean, you can have a look at the questions and things in there. Everybody is saying it's one of the best they've been to, and I would concur with that. So thank you so much for such an interesting topic. And I may tap you again if that's all right.
Sure, I'd be honored. I'd be really honored. Thanks for asking me. I feel very, very honored, and like I said, I'm very excited because it makes me feel a wee bit closer to home.
Yeah, just hearing the accent, is that what it is?
Yes.
Well, listen, everybody, the thanks are still coming in, so they are. So and people are just asking about the slides, so you're going to share those on the Behaviour Live site.
How do I do that? You can tell me how to do that.
Okay.
Yes. And people can also email me. There's my email, and I will figure out how to share the slides.
Here it says material handouts at the bottom. You could just upload them there if you want, or you can, and people can.
Brilliant! I'll do it right now. I can do it right now.
And again, Evelyn, thank you so much. And for everybody who's still here or will be watching, these sessions are recorded, so you can go back and watch them again. And tune in for our next one in July. That will be starting, our next webinar will be starting to advertise in the next day or so. So tune in for that. And again, Evelyn, thanks so much, and have a lovely day. We're all getting ready for bed, and you're getting ready to really start your day, I'm assuming, or are you nearly finished?
No, I have back-to-back sessions right after this.
Right. Well, we're definitely going to let you go then.
No worries. I am uploading the PDF, so it should be there. It should be there in the next 5 minutes or so, I think, for people.
Brilliant.
Yeah, those of you who are in here, you can just leave the talk open, and once the upload's done, it'll show in her handouts tab at the bottom. It'll pop up. So otherwise, you can access this after the fact as well. So thank you, everyone.
Thanks. And thanks so much, Chris. Thank you.
My pleasure.
Evelyn, I'll be in touch. Thanks.
Okay, thank you. What do I do here to sleep?
I'll close us out.
Oh, you're